This is a 49-year-old male patient who's diabetic, presented with confusion and a CT to rule out stroke. The CT you're looking at is a CT without intravenous contrast administration. This is a good case for radiology residents and people interested in neuroimaging. However, juniors would get something or two out of it. Speaking of which, before I continue with this case, please check our Radiology Bits account on Twitter, where you'd find our first pinned tweet that talks about our new webinar, which is next Wednesday, where we'll have about an hour of discussing 5 to 10 interesting cases. The cases would be shown as unknown chest X-ray cases, and the target audience is mainly juniors. Using these cases, we'll have a chit-chat about interesting findings and a few teaching points. The teaching points would be most useful for medical interns and students. I think junior residents who just started would benefit from that as well. Another group that could benefit would be residents who are in non-radiology specialties. So students and interns, please check the provided Twitter account and join us if you think this would be of use. Now that you had a chance to look at the case and think about it, the abnormality is really striking. This is a CT of the head without contrast, and you see lots of bright stuff. We now know from previous discussions that hyperdense or bright stuff on CT may represent hemorrhage, but it could represent other things as well. Hyperdensity on CT could be due to IV contrast, but it could also be due to calcifications or metal. The main abnormality is calcification of the caudate nucleus, lentiform nucleus, and thalamus. Not only that, the calcifications are extremely dense and they're bilateral and symmetric. You also see these faint calcifications in the white matter, some of which are scattered, subcortical, and gyriform. They follow the contour of the gyrus. As you go to the posterior fossa, the cerebellar hemispheres are symmetrically calcified as well. Although the calcification involves a large area, the area that's involved also includes what we know as the dentate nuclei. For junior residents, remember that you will see calcifications when you do brain imaging, but that's typically not as extensive, not as symmetric, and it should be seen in known locations for normal calcium deposition, typically in patients above 50 years old. As we said, it's not going to be as extensive as you see here. Where do normal calcifications in elderly occur? Normal calcifications that are related to aging are commonly seen in the basal ganglia, in particular the inner aspect of the basal ganglia, which is known as the globus pallidus. However, when you see that, these are usually heterogeneous, punctate, and faint. Another location for calcification would be this area here. So this is the region of the pineal gland and what surrounds it. It's also very common, especially with aging, to see calcification that is small within the pineal gland. And the collection of neurons in front of the pineal gland is called habinula. This could also calcify as well. Another location for normal aging calcification would be the meninges and what's arising from it. By that I mean the dura covering the brain could have some calcifications that are scattered. The same could happen within the falx cerebri and the tentorium cerebelli, structures that we talked about in a different case last week. You may even see a minor degree of calcifications within the dentate nuclei of the cerebellum, of course not as extensive as this. Another normal structure that calcifies is the choroid plexus within the ventricles. This is something that you see commonly, calcification of the choroid plexus that lives inside the CSF of the ventricles, especially in the posterior horns. As you go higher above, even without contrast, you see this thick band that's midline. This is the superior sagittal sinus. And with aging, you may normally see some calcifications that involve the sinus. Another structure that could calcify is the vessel. So you could see vascular calcifications with aging. Now that we talked about normal and aging calcific structures within the brain, you know that this is more extensive than that and it does not fit. Given that the patient is relatively asymptomatic and that the calcifications are extensive and symmetric, add to that the calcifications are in a classic location, this is most likely consistent with something called Fahren's disease, which is a rare neurodegenerative disorder of the brain. So this interesting entity of Fahren's disease that is rare, as we said, is typically familial, could be autosomal dominant or recessive. Extensive calcifications deposit in the basal ganglia thalami, in the subcortical white matter, and in the dentate nuclei. Deposition in these areas lead to a slowly progressive neurodegenerative presentation. At a certain point, the patient may be relatively asymptomatic, but as the disease progresses, he may present with some classic symptoms. The patient may present with one of those: psychiatric, cognitive, or movement abnormalities. Psychiatric presentations such as schizophrenia, cognitive such as dementia, and movement such as Parkinsonism. Typically, younger patients present with psychiatric disorders, while the older patients present with movement and cognitive abnormalities. Now, we know that this is more extensive than aging. It's typical of Fahren's disease. Is there a differential diagnosis? The differential diagnostic list for calcifications in the basal ganglia or other regions of the brain is actually a very long one. However, the most important category to differentiate here is that of metabolic disorders. A common metabolic disorder that could lead to something that's similar is hyperparathyroidism. A major differential factor between metabolic disorders and Fahren's disease is the calcium phosphate level in the blood. The calcium phosphate level in the blood is completely normal with Fahren's disease, while it's abnormal with metabolic entities. So as a radiology resident reading the case, this is something you could recommend the clinician to do to differentiate between these entities. Now, other funny metabolic disorders that could lead to the same thing would be hypoparathyroidism, pseudo-hyperparathyroidism, and pseudo-hyperparathyroidism. We're not going to go over these very rare metabolic entities, but they're famous entities. You know what? Just say them, they make you look good. To a more important discussion, can you have calcifications from other reasons? Yes, you could. But whatever we're going to mention now is usually easier to diagnose given the clinical presentation or other associated findings. So chronic insults such as a remote infection, whether it's TB, toxoplasmosis, HIV, cysticercosis, may give you calcifications within the basal ganglia or other structures of the brain. Another remote insult from hypoxic ischemic injury may lead to the same thing. More so, a remote exposure to toxins such as carbon monoxide could give you an appearance of the patient survives. And some drugs. The classic combo is giving the patient radiation for a tumor with intrathecal injection of chemotherapy. For juniors, by intrathecal injection, meaning that you inject the chemotherapy into the CSF to be more effective. Finally, calcifications in the brain may be abnormally seen with syndromes such as tuberous sclerosis, Down syndrome, or other even rarer syndromes. So that concludes today's case. Here's another look at this impressive case of Fahren's disease. We learned that Fahren's disease is a rare, slowly progressive, typically familial neurodegenerative disorder where extensive and classically symmetric calcifications of the basal ganglia, thalami, white matter, and dentate nuclei are seen. We learned that this disease may present as psychiatric, cognitive, or movement disorders. The differential diagnosis starts by knowing where normal calcifications may occur, especially with aging, and normal calcifications could happen in a faint way within the basal ganglia, pineal gland, habenula, dura, falx, tentorium, superior sagittal sinus, dentate nuclei, or vessels. And whenever you see extensive calcifications in a younger patient, try to think about a differential diagnosis, since calcifications are more likely to occur in older patients, patients who are older than 50 years old. The main differential diagnosis also includes metabolic disorders such as hyperparathyroidism, and also remote insult from toxins, ischemia, infections, radiation, and could be seen with syndromes such as tuberous sclerosis, where the patient is usually known younger and has other manifestations. Well, that concludes today's case. Thanks for watching. Your comments are appreciated as usual, and see you with more cases later. Hello again. This is a 50-year-old female patient who presents with left shoulder pain for 2 weeks. Now, some followers have asked for an advanced case. Others have asked for a musculoskeletal case. This is a case that fulfills both. This is the left shoulder MRI. This is an axial T1. Here's the sagittal T1. I'm going back and forth. This is a coronal T2. This is an axial proton density, PD, where you have suppression of the fat. This is another fat-sat PD in sagittal acquisition. And finally, a coronal fat-sat PD as well. The major finding, as you see here, is this homogeneous, relatively well-defined hypointense area. So the humeral head has this lesion that's obviously seen on T1, and it also has some heterogeneity adjacent to it. On the sagittal T1, the lesion is so obvious, and you also have these smaller scattered similar intensity lesions. Here's the coronal T1 again. It's not a bad image to show some anatomy for the junior followers. This here is the proximal humerus. This is the glenoid of the scapula. On the same plane, you see the clavicle as it goes all the way to join this part of the scapula, the acromion. So this is the acromioclavicular joint. And you have the tendons and muscles that pass between the humerus and the AC joint. These are the rotator cuff tendons. The space between the humerus and glenoid has this hypointensity on T1 that extends inferiorly within a recess. Since fluid is dark on T1, this could be an effusion, and you could confirm that by looking at T2 weighted sequences. So this is a T2 weighted acquisition in the same coronal plane, where you see that this here is very bright, consistent with an effusion. So we have this small joint effusion that's confirmed by low intensity on T1, high intensity on T2. The lesion that was seen on T1 is also seen in the proximal humerus on T2 as a low to intermediate signal intensity abnormality. As we know from prior clips, edema is good to see on T2 weighted sequences. However, it's very difficult to differentiate from fat here. So without suppressing the fat, it would be difficult to differentiate what you suspect as edema that's bright in this region from the rest of the normal fatty marrow. So let's look at the PD in the same plane. You see the effusion that appears bright on PD, similar to what you see on T2 acquisitions. This is an axial proton density showing the proximal humeral abnormality as being bright. Not only that, despite the use of fat saturation, the humerus shows heterogeneous areas of high signal intensity. And this confirms the presence of edema in the proximal humerus. So the proton density shows these areas of high signal intensity despite the fat suppression, consistent with edema. Since we did this examination to assess rotator cuff, we did not give contrast. However, contrast would have been very useful here. Now, can this be an infection? If it's a septic joint, you'd expect the changes to be seen on both sides of the joint, humerus and glenoid, which is not the case here, so an infection is less likely. You cannot exclude the possibility of osteomyelitis, however. The focality of the abnormality would make osteomyelitis a bit less likely. This really looks like a focal soft tissue abnormality, which we did not assess completely because we did not give intravenous contrast. Now, other than neoplasms, could you have another abnormality that affects one side of the joint without affecting the other? The answer is yes. In the earlier stages of avascular necrosis, only one side of the articulation is involved, while the other is spared. So could this be avascular necrosis? The focality of the abnormality argues against that again, and the presence of these smaller foci here would be unusual for avascular necrosis. Another point against AVN is that if you had this size of avascular necrosis, you'd expect to see some collapse, which is not the case. Whatever we're seeing here is taking us to square one. This looks neoplastic. There is a problem with this case, however. The first problem is your mindset. When you're looking at cases that are protocoled as rotator cuff abnormality, you rarely think about malignancies. And the fact that you do not give contrast makes this more difficult, because if you gave contrast and you see typical enhancement, you'd really push for a neoplastic process. The other problem with this case is what we know as satisfaction of search. This is a mistake that we try to remind ourselves not to fall into. You see a very obvious abnormality and you forget to look at the remainder of the scan. Speaking of which, have you noticed those? And this shows you multiple lung nodules at the edge of the film. Now that you see those, you're really thinking about metastasis. And the lesion involving the proximal humerus could be metastatic as well. This is the patient's shoulder x-ray a few days before. Although it's very difficult to comment on any humeral abnormalities, the lung lesions are so clear. So again, don't look at the bones or the joints and forget to look at the rest of the examination. Satisfaction of search is a dangerous thing. Here's the chest x-ray that shows the multiple bilateral nodules, which are consistent with metastasis. Now, I'm sure you see these nodules clearly, but please don't tell me that you fell into the pitfall of satisfaction of search again. If you're systematic, you look at the hidden areas, including the lung apices and particularly behind the bones in these regions. And doing that, you clearly see the asymmetry in density overlying the medial clavicle on the left versus that of the right. So there is a larger irregular opacity that lies in the right lung apex. Putting everything together, you'd suspect that this is likely a primary lung cancer with metastasis to both lungs and to the left humerus. Here's the CT chest on the same patient. The multiple bilateral nodules, some of which are cavitary, are obvious. And here you could clearly see the dominant right upper lobe lesion, which has a speculated appearance and looks a bit different than the other nodules. So this is your likely a primary lung cancer, and this is a cavitary metastasis. Let's not forget to look at the bones on the CT chest, and here you see the lesion that was clearly detected on the MRI. There's a very heterogeneous appearance of the proximal humerus, and the soft tissue abnormality involving the proximal humeral head leads to cortical disruption as well. So this is the soft tissue mass involving the proximal humerus, and you'd wonder if the adjacent changes are either loculated fluid versus extension of the soft tissue mass itself. Now let's summarize what we learned today. First, it's not only rotator cuff abnormalities that could be detected on a routine rotator cuff MRI protocol. So look at the bones and bone marrow in a very careful way and keep your mind open to other possibilities when reading such examinations. With such a case, it would be advised to bring the patient back and do the examination after administration of intravenous contrast. One important point in approaching such abnormalities is to decide if the abnormality is involving one or both sides of the joint. What's even more important is not to fall into satisfaction of search pitfall. You have a lesion here and you have lung nodules there, so don't miss that. The same concept was emphasized when we looked at the shoulder x-ray where there were nodules in the lung, so don't forget to look at everything you have. The concept was emphasized again when we looked at the chest x-ray. We saw the nodules, don't forget to go systematic and look at your hidden areas. And the lung APCs, where you have the first rib, the clavicle, the sternal junction, is a crowded area and considered a hidden area to look carefully at. Since you have both sides, use symmetry to help you detect such abnormalities, and here the abnormality created an asymmetric appearance. And finally, be very careful when looking at chest CTs and don't miss looking at peripheral structures and bones as well. And by that, I thank you for watching and see you with more cases next week.